Good morning, everybody. I would like to welcome you to Immunic's webcast to present the positive results from our phase 1b clinical trial of IMU-856 in celiac disease patients reported this morning. My name is Jessica Brew, Head of Investor Relations and Communications at Immunic. I will also be the moderator on today's webcast. Speaking on the call are Dr. Daniel Fitt, our Chief Executive Officer and President, and Dr. Andreas Müller, our Chief Medical Officer. Please note, all participants will be in listen-only mode, and this event is being recorded. After today's presentation, there will be an opportunity to ask questions. If you joined the webcast via the Zoom platform, there are two ways to submit questions. You can either submit your questions in writing via the Q&A tool of the Zoom portal, or if you would like to speak with us directly, please use the raise hand function in the Zoom portal to queue your question. Before we begin, I would like to remind you that this presentation may contain forward-looking statements. Such statements can be identified by words such as may, will, expect, anticipate, estimate, or words with a similar meaning. And such statements involve a number of risks and uncertainties that could cause Immunic's actual results to differ materially from those discussed here. Please note that these forward-looking statements reflect Immunic's opinions only as of the date of this presentation, and it undertakes no obligation to revise or publicly release the result of any revision to these forward-looking statements in light of new information or future events. Please refer to Immunic's SEC filings for a more detailed description of the risk factors that may affect Immunic's results and these forward-looking statements. I would now like to turn the webcast over to our CEO and President, Dr. Daniel Fitt, to kick off the presentation of our great IMU-856 celiac disease data. Daniel?
Yeah, thank you, Jessica. Yeah, this is a very important day for us and for patients worldwide who are suffering from gastrointestinal diseases. To start right away, we have 4 key take-home messages from today's data presentation. With today's data, we are establishing a new treatment concept for intestinal diseases. IMU-856 targets the renewal and regeneration of the intestinal wall, which has now been demonstrated for the first time by clinical benefits. We've seen consistent clinical benefits across 4 dimensions of clinical outcomes for celiac disease patients in this phase 1b trial of IMU-856. Confirming our previously presented data in healthy human subjects, IMU-856 has been shown to be safe and well tolerated in this trial. As the next step, Immunic is currently preparing for clinical phase 2b testing in ongoing active celiac disease patients. The data generated from this proof of concept study tells us that IMU-856 could be a real game changer in the way we treat gastrointestinal diseases. But how does it work? IMU-856 represents a completely different approach in this field. When we started the development of these compounds, the idea was simple. Can we restore the natural regeneration of the gut wall? Can we do this without blocking or disturbing the immune response of patients? Is it possible to have a simple pill taken orally once a day? Our concept is highly unique. Instead of suppressing the immune system or trying to eliminate antigens or pathogens in the gut, we're aiming to restore the normal, healthy gut wall. The human gut is a very active organ. It is responsible for absorption of nutrients, but also a gatekeeper to ensure that no unwanted matters, such as bacterial proteins or other antigens, pass the gut wall and then interact with the immune system of the gut. To ensure the proper function of the gut wall, the tissue is continually renewed. This gut wall renewal is a normal physiological function in healthy humans. The renewal starts with the so-called asomatic division of intestinal stem cells, a process which leads to self-renewal of the stem cells and to production of differentiated gut epithelial cells. These epithelial gut cells renew the lining of crypts and villi and maintain a healthy gut and proper intestinal barrier. IMU-856 is a new molecule with a new mode of action. It modulates an epigenetic regulator protein target, which is specifically expressed in intestinal stem cells, enterocytes, goblet cells, and Paneth cells. We plan to present details on this unique mode of action in the context of an upcoming scientific conference very soon. With this mode of action, IMU-856 represents a completely new approach for the treatment of gastrointestinal diseases through its ability to restore a healthy gut by regenerating and renewing the gut wall. As already mentioned, we have chosen celiac disease as the first proof of concept indication for IMU-856 as an oral treatment for gastrointestinal disorders. Celiac disease is a serious, lifelong autoimmune disease caused by gluten in patients with a specific genetic disposition. Gluten is degraded to gliadin peptide, which can cross the gut wall and then can bind to a protein called transglutaminase 2 or TG2. TG2 modifies gliadin, and this complex can be recognized as an antigen by the immune system in patients with specific HLA-DQ2 and DQ8 antigen variants. This causes an immune response, and the resulting inflammation then triggers bowel tissue destruction and celiac disease symptoms. IMU-856 aims to regenerate the bowel wall and also restore the proper barrier function in celiac disease patients without disturbing the immune system at all. As we know so far, our approach is fundamentally different from concepts used by other biotech or pharma companies, which mainly target either the immune response or antigen processing. In addition, some facts about celiac disease that show the high unmet medical need for this disease. 2 million patients in the United States are diagnosed with celiac disease, and more than 1 million people go undiagnosed. Of those, between 24 and 47% of patients have signs or symptoms of ongoing active celiac disease, or OACD, despite adhering to a strict gluten-free diet, most likely due to continuous inadvertent gluten exposure, mainly from contaminations. The only established therapeutic option today is a lifelong strict adherence to gluten-free diet, which involves complete avoidance of proteins from wheat, barley, and rye. What is important for our trial, gluten challenge is an accepted concept for clinical trials in celiac disease. So let's look on the results of our phase 1b clinical study in patients with celiac disease. Today, we are showing the first clinical results of IMU-856 in patients. In all the 4 relevant dimensions of celiac disease, IMU-856 showed an advantage over the control group. It is remarkable to see the consistency of beneficial results across key disease dimensions and how clearly all these parameters fit together in paving the way for further development of an effective treatment for gastrointestinal disorders without suppressing the immune system. IMU-856 shows positive effects in 4 dimensions of clinical outcome in celiac disease patients: protection of the gut architecture, improvement of patient symptoms, biomarker response, and enhanced nutrient uptake. With regard to the first dimension, protection of gut architecture, IMU-856 effectively reduced gluten-induced intestinal damage in this trial as measured by villus height. Secondly, looking at symptoms, IMU-856 also reduced or reversed gluten-induced symptoms of disease activity reported by patients. Thirdly, in terms of biomarker response, IMU-856 dampened gluten-induced immune activation as measured by IL-2, and in addition showed a positive impact on the gut health marker citrulline. Interestingly, as the 4th dimension, IMU-856 also showed restoration of villi absorption function, resulting in an improved uptake of nutrients, such as, for example, vitamin B12 or zinc. And what is really remarkable is that all of these effects were seen without any suppression of the immune system. I'm happy to now hand over to my colleague and Chief Medical Officer, Andreas Müller, to walk you through the more detailed data. Andreas, please go ahead.
Thank you, Daniel, and good morning, everybody, and thank you for your interest in our data. I would like to start by outlining the trial design as well as the patient population included in this trial. Before I get to the results, may I please address the Immunic team that was involved in the planning and execution of this trial, which allowed me here today to have the opportunity to present these wonderful data. I know that you're listening in as well. Many thanks for your hard work and dedication. Well done, team. We are reporting today the results from the final portion of our phase 1 clinical trial of IMU-856, Part C, which was performed with 28-day daily dosing of IMU-856 or placebo in celiac disease patients. The study used two different doses of IMU-856, 80 and 160 milligram, which were given in a tablet form once daily. In sum, we had hoped that Part C of this trial would demonstrate that a therapeutic intervention with IMU-856 in a celiac disease population results in regeneration and renewal of the bowel wall. As you will see momentarily, the drug met this challenge incredibly well. And on a personal note, I have to say that days like this make being part of the biotech community and being dedicated to the development of new therapies for patients so rewarding. For this trial, the 28-day treatment period was split into two portions. For the first 13 days of dosing in, patients received IMU-856 or placebo without any gluten challenge. This period was designed to allow IMU-856 to develop the impact of its proposed mechanism of action, regenerating or renewal of the bowel wall. This initial 13-day period was followed by a 15-day gluten challenge period using 6 grams of gluten given each day, starting on day 14. The gluten challenge is equivalent to about 2 slices of bread on a daily basis. On the first day of gluten challenge, day 14, we also measured interleukin-2, or also known as IL-2, as a biomarker measurement for the immune stimulation in the bowel wall. The first day of gluten challenge usually produces the highest immune stimulation, which was why we chose to measure IL-2 on that day. Finally, at the start and at the end of the trial, a biopsy was performed via gastroscopy, allowing us to measure the histologic changes in the gut. During the entire trial, celiac disease and gluten-related symptoms were monitored. In total, 43 celiac disease patients were randomized and 35 patients completed this trial. As can be seen from the table below, symptoms related to the gluten challenge, not unexpectedly, were the most prevalent reason for trial discontinuation by patients. We believe that this rate of discontinuation still has to be considered low for a gluten challenge study in which the gluten challenge induces symptoms and makes daily activities difficult for these patients. Note that in the highest dose group for IMU-856, no gluten-related discontinuations occurred. The slide also highlights the number of patients who reached day 14 for measurement of IL-2 and the first day of gluten challenge, and those who reached day 29, the day of the second biopsy, to explain the number of patients for histologic evaluations. Our inclusion criteria were designed to include well-controlled celiac disease patients. Specifically, patients had to have followed at least 1 year of gluten-free diet, had to be seronegative, both in terms of transglutaminase 2 or TG2 serology, and negative urine gluten immunogenic peptide, as well as not having any signs or symptoms indicative of villus atrophy. Notwithstanding these inclusion and exclusion criteria, the IMU-856 treatment arms contained nearly 60% of patients with more severe stages of the disease, QMAR stages M3A and M3B, that are known from the literature to lead to stronger symptoms and histological deterioration during gluten challenge, essentially biasing the study against the active treatment arms. The upshot of this enrollment outcome is that the study had more serious celiac disease patients enrolled, implying a tougher challenge for IMU-856 to prove itself. Perhaps more importantly, patients with a disease profile characterized by MARSH stages M3A, B, and C are considered to be ongoing active celiac disease or OACD patients. And these are the exact patients that the new FDA guideline requests for inclusion in patient populations for phase 2 and 3 studies. Hence, the results from this phase 1b trial reflect to a significant degree the phase 2 population that would be incorporated in our next set of trials. Thus, the results of this phase 1b trial could potentially enable better planning for our future phase 2b trial. So let's look at first and the most important dimension of drug effects, histology. This slide gives you a visual impression of the bowel architecture and changes that happen during gluten exposure for celiac disease patients and, of course, during the gluten challenge of our trial. On the left, you see the villi, the small finger-like projection that extend from the surface of the bowel into the lumen of the small intestine. They are, under healthy conditions, approximately 500 microns in length and act to extend the surface of the bowel for nutrient uptake. When celiac disease patients are exposed to gluten or to a gluten challenge, like the one in our trial, the resulting bowel wall inflammation leads to a reduction of villus height. This is the earliest and most sensitive marker of deterioration of bowel architecture. Shorter villi also have less surface area, and therefore absorption of nutrients is decreased. The bowel wall also has crypts, which are tube-like pockets found in the bowel wall, which contain cells that renew the lining of the intestine and make mucus. Eventually, with longer gluten exposure, the crypts become elongated, and hence the villus height to crypt depth ratio is used to define the severity and stage of the celiac disease. Let's start with the first essential input into this equation, villus height, and see the results for that metric in our trial. As expected, patients who received placebo and underwent gluten challenge with 6 grams daily for 15 days showed an approximate 60 micron reduction in villus height. Both IMU-856 treatment arms showed substantial protection against the deterioration of villus height. In fact, villus height only decreased by about 20 microns in these patients. Furthermore, an exploratory statistical analysis of the pooled IMU-856 treatment arms as compared to the pooled placebo patient showed a statistically significant difference. Since villus height largely influences nutrient absorption, this is also relevant for the influence on known potential medical complications of celiac disease, such as anemia or osteoporosis. I also would like to point out that histology was assessed in this trial by an independent central lab and by a blinded pathology reader to winnow out unintentional biases in the evaluation of these markers. We also employed a very experienced pathology laboratory that has been used by many other prior clinical trials in celiac disease. This slide shows you a waterfall plot with the individual changes in villus height for all 35 patients who completed the trial and had both the pre and post-exposure biopsies completed. The plot shows the individual variability of the changes of villus height between patients. What is also visually apparent is that most of the placebo patients, marked in orange here in this plot, are on the right side, where the most severe reduction in villus height are located, whereas the patients treated with IMU-856 are more on the left side, marked in medium and dark blue, where more minor changes in villus height are located. In fact, there are a number of patients treated with IMU-856 who show a more than 5% increase and up to 15% increase in villus height. This showed that IMU-856 treatment may not only protect against the deterioration of bowel architecture during a gluten challenge, but may be allowing for improvement in villus height despite the relatively short 28-day treatment period. As mentioned a few minutes ago, celiac disease severity is assessed by the Q-Marsh score based on the quantitative assessment of villus height divided by crypt depth. This is exemplified in this slide. With increasing severity of disease, villus height decreases and crypts elongate. The resulting decrease in villus height to crypt depth ratio is then used to define the different stages of disease, from M0 Q-Marsh score that represents a normal bowel to stages M3 A, B, C that are summarized as ongoing active celiac disease or OACD. So let's take a look at the trial population and whether and how patients changed by at least one severity category during the 28 days of treatment. The table on the right shows the different Q-Marsh disease stages and the corresponding Willis height to crypt depth ratios. We queried our data set to assess whether patients had a transition to another Q-Marsh category between baseline and the end of the trial. As expected in a gluten challenge trial, many patients experienced a deterioration in at least one category upon exposure to gluten, regardless of treatment arm. However, only about 1/3 of the 80 milligram IMU-856 patients and less than half of the 160 milligram IMU-856 patients experienced this kind of deterioration, while approximately 2/3 of the placebo patients had Q-Marsh deterioration of at least one category. We were encouraged to see these results as we saw that the potentially protective effects of IMU-856 can actually be measured and quantified by the marker of Willis height to crypt depth. What is unexpected is that there were 2 patients in the IMU-856 treatment arms, one in each dose group, who experienced an improvement of at least one category despite undergoing gluten challenge and having a short treatment of 28 days only. No improvement was observed in any patient in the placebo group. Interesting to notice that the endpoint of improvement of bowel architecture on a per patient level is a component of the FDA recommended guidelines for phase 3 study in this space, though of course, as part of a trial with an extended treatment time and without a gluten challenge. In summary, we believe that the data on histologic changes that we have seen in this trial are a compelling signal supporting the mechanism of action of IMU-856 in achieving better quality of bowel health through the promotion of bowel wall regeneration. Now we're coming to the second dimension, the patient's symptoms. As gluten challenge will induce a range of acute and ongoing, symptoms. 5 of the most predominant gluten-related symptoms are measured by the Celiac Disease Symptom Diary, or CDSD, which is the best validated symptom score in celiac disease that has also been used in a number of previous celiac disease trials. I will show you the results for all 5 of these symptoms included in the CDSD. For the CDSD, each patient was asked to assess each of the 5 symptoms on each day of treatment on a scale going from 1 for none to 5 for very severe. This means each symptom has a possible 4-point range. This first slide here shows the 3 most acute symptoms: nausea, abdominal pain, and diarrhea. Displayed is the change of the symptom score from the evening before the first day of the gluten challenge, day 13, to the evening on the first day of gluten challenge, day 14. As can be seen, the score for each symptom changes for placebo-treated patients by 0.8 points. This is a substantial worsening of each of these symptoms on the first day of gluten challenge. The symptoms for IMU-856 treated patient also worsen on the first day of gluten challenge, however, consistently to a much lesser degree. This shows that IMU-856 seems to have a protective effect for these acute symptoms following the first day of gluten challenge. Let's have a look now at what happens when patients continue to be treated with IMU-856 during the 14 remaining days of gluten challenge. This slide provides a summary for the 4th symptom measured in the CDSD, bloating. Consistent with the other symptoms, and as you can see on the left side on the slide, bloating worsens in placebo-treated patients and, to a lesser degree, in IMU-856 treated patients on the first day of gluten challenge. However, when patients then continue to be treated with IMU-856 over the 14 remaining days of the gluten challenge, and that's what you see on the right side, the bloating is reversed until the end of the gluten challenge at day 29, and the baseline values are again reached. In placebo-treated patients during the last 14 days of gluten challenge. Bloating never reverses and actually slightly worsens further. The same pattern can be seen with the fifth symptom of the CDSD, tiredness or fatigue. Again, the tiredness worsens with the first day of gluten challenge dose for placebo-treated patients and to a much lesser degree for IMU-856 treated patients. And then during continuing treatment with IMU-856 over the next 14 days of gluten challenge, the symptom tiredness is reversed and baseline values are reached again. Whereas in placebo-treated patients, the tiredness still slightly worsens to the end of the gluten challenge. In summary, the data show that IMU-856 treatment has a protective effect on the 5 symptoms measured with the CDSD on the first day of gluten challenge, and continued treatment with IMU-856 seems to have a positive effect to further reduce or reverse at least some of these symptoms. So let's continue with the third dimension of effectiveness assessments in this trial, biomarkers. This slide summarizes the results for the biomarker serum IL-2. But first, some scientific background. When a gluten challenge begins after a patient has followed a gluten-free diet for a while, there's a strong immune stimulation of T cells in the bowel wall that is triggered by the sudden presence of gliadin, in particular on the first day of gluten challenge. This immune stimulation of T cells can be measured by the increase of IL-2 in blood. The slide displays the change of IL-2 from the morning of the first day of gluten challenge, just before the gluten challenge starts, to 4 hours after the start of the gluten challenge. This is known to be the time of peak serum IL-2. We have used 2 different test systems for IL-2 measurement. IL-2 is sometimes difficult to measure, and we have included both test systems to investigate if we found a similar pattern of results. This is what we have found here. The chart displays the average change for each treatment arm, as well as the maximum change found in that treatment arm. The results for both test systems show that with increasing doses of IMU-856, the average as well as the maximum change is reduced in a dose-dependent fashion, suggesting less T cell stimulation in the IMU-856 treated patients. IMU-856 has no known effects on the immune system, so these results cannot be explained by influencing the celiac disease-related autoimmune mechanisms. Here, the likely explanation is that IMU-856 in the dosing in period of 13 days before the gluten challenge was able to strengthen the bowel barrier function so that less gluten and gliadin were able to enter the bowel wall to stimulate the T cells. The results for the biomarker IL-2 seem therefore to be a confirmation of the secondary effects of reducing bowel permeability as a result of bowel wall regeneration. The next biomarker is citrulline. This is a very different biomarker. Citrulline is a non-essential, non-proteogenic amino acid that is released from enterocytes, the epithelial cells lining the bowel wall. Because plasma levels of citrulline are reduced in case of impaired intestinal function, it has become a biomarker to monitor intestinal functional and metabolic health of the enterocyte. Normal plasma citrulline concentration in healthy adults have been defined as around 40 micromole per liter. In the first 14 days of the dosing in period, until the morning of the first day of the gluten challenge, on the left side of the slide, IMU-856 in a dose-dependent fashion provides a meaningful increase in citrulline. This seems to indicate that IMU-856, possibly through the proposed mechanism of bowel wall regeneration, also improves the health and function of the enterocytes lining the bowel wall. On the right side of the slide, you can see that this positive effect on citrulline can also be maintained throughout the trial, including the gluten challenge period. In all periods, the citrulline level decreased for placebo-treated patients. The increased citrulline level following treatment with IMU-856 seems to indicate the increase in the quality and health of the enterocytes, which play a major role in the bowel wall. It needs to be noted that the biomarker citrulline has also been shown to correlate with intestinal disease severity in several other bowel diseases, including Crohn's disease. Now I will show you the results for the fourth dimension of effects of IMU-856, namely its ability to improve nutritional absorption. Celiac disease is known to have a large component of signs and symptoms of malabsorption and malnutrition. Many of the medical complications associated with celiac disease, such as anemia and osteoporosis, are a result of malabsorption and malnutrition. This slide summarizes the change in plasma vitamin B12 levels between baseline and day 29 at the end of the trial. This marker is interesting insofar as vitamin B12 is absorbed in the small bowel by an active transport system. IMU-856 increases the absorption of vitamin B12 in a dose proportional fashion, whereas absorption in placebo-treated patient is further reduced in this trial by the gluten challenge. This increase in vitamin B12 is likely a result of improving the health of the enterocytes, in similarity what I discussed earlier for the biomarker citrulline. And the same beneficial pattern of nutrient absorption can also be found in other markers, such as zinc in this case. This duplicates the same positive pattern for IMU-856 we just saw for vitamin B12. Finally, the beneficial effects also include the iron metabolism and absorption, as can be seen from the ferritin levels on this slide. This is insofar important as anemia is a known complication of celiac disease. We were also able to evaluate whether these beneficial effects on iron metabolism and absorption can translate into red blood cell function. This slide shows the change in MCHC in this trial, basically the average hemoglobin concentration in each red blood cell. IMU-856 treated patient can increase the amount of hemoglobin that can be packed into each red blood cell. Hemoglobin contains iron. In summary, these results demonstrate that IMU-856 treatment shows beneficial effects on all 4 dimensions of effectiveness measurements: histology, disease symptoms, biomarkers, and nutrient absorption. The effects go beyond just protecting the gut to include improvements in gut health that are relevant to this disease, but also to other gastrointestinal diseases. The signals of IMU-856 treatment as compared to placebo in this trial consistently suggest positive effect on many of the measured endpoints and seem to indicate a clinical proof of concept for the proposed mechanism of IMU-856, which results in the regeneration and renewal of the bowel wall. Both doses of IMU-856 in this trial were found to be active, and in most cases, there was a dose-dependent response with the higher 160 milligram dose being more active than the lower 80 milligram dose. We're turning now to safety and pharmacokinetics. IMU-856 was found to be safe and well tolerated, and no specific safety signal has been observed in this trial, consistent with the results from parts A and B of this phase 1 trial in healthy human subjects that were reported to you last year. This slide summarizes the adverse events in this trial. No dose dependency was found in adverse events. There were no IMP-related severe adverse events, nor any IMP-related serious adverse events. As discussed earlier here in this call, there was a higher prevalence of more severe patients in stages M3A, B, C, included in the IMU-856 treatment groups. This slide shows you an analysis that these patients with the more advanced, more severe stages of the disease are the source of the disease-related adverse events found in this trial. The higher number of disease-related adverse events over the entire study period for IMU-856 treated patients are therefore results of the prevalence of more advanced disease and independent of the improvement in disease-related symptoms shown for IMU-856 as compared to placebo during the 15-day gluten challenge. As IMU-856 does not have any known effects on the immune system, We also have not found effects on hematological parameters in this trial. Exemplified here for neutrophils, the number of immune cells is stable over the trial period. The trial also did not show any signal for elevations of liver enzymes or bilirubin. No Hy's law cases were found in this trial. This slide summarizes that no effect of IMU-856 on EKG and in particular on the QTc interval was found in this trial. Here we present the trough levels and the main pharmacokinetic results from this trial following once daily oral tablet administration. Steady state trough levels were reached within the first week of dosing. The pharmacokinetics show a dose linear behavior, basically showing a doubling of exposure in blood when doubling the oral dose administered. Before I hand the microphone back to Daniel for a summary of results and an outlook for the further development of IMU-856, I would like to thank the investigators, site staff, the patients, caregivers, as well as our medical advisors and vendors who worked tirelessly throughout this trial, always with the belief that IMU-856 could be a completely new paradigm in the treatment of celiac disease. I hope you will agree that these results support this vision and could potentially support additional clinical research in a wider array of gastroenterological diseases. Daniel, back to you.
Yeah, thank you, Andreas. A lot of data was presented today, and as I hope you can feel, we are quite excited about the potential of this program. We are very pleased to see that IMU-856 shows positive effects in each of the main 4 dimensions of clinical outcome in celiac disease patients. In summary, in this phase 1b trial, IMU-856 prevented histological damage, showed a consistent benefit on symptoms over placebo, demonstrated a dose linear response for IL-2 and citrulline levels, and enhanced nutrient uptake. On top of these strong efficacy results, IMU-856 also showed a clean safety and tolerability profile and favorable pharmacokinetics. With these effects, IMU-856 demonstrated strong potential to restore a healthy gut in patients, starting from regeneration of the bowel architecture to normalization of bowel wall permeability. Let's also look into the future. Although we clearly first want to take the compound further in celiac disease, our vision for IMU-856 goes beyond celiac disease, as this concept is even more universal: restoration of a healthy gut wall and environment. For example, on the left-hand side of this slide, it was shown by Wyatt et al. In the Lancet publication that the risk of a disease flare-up in patients with Crohn's disease increases with higher permeability of the gut wall. After half a year, more than 50% of the high permeability group had a disease flare, whereas less than 20% of the Crohn's patients with normal permeability experienced the flare. As shown in the graph on the right, patients with ulcerative colitis or irritable bowel syndrome with diarrhea also shown an increase in intestinal permeability. Therefore, we believe that this concept may also be highly relevant for these indications. Immunic is currently working on clinical phase 2b preparations for celiac disease, but also would be keen to expand development activities to additional gastrointestinal indications such as Crohn's disease or ulcerative colitis, diseases with high number of patients affected. So let me summarize what we learned about this exciting once-daily oral treatment option for gastrointestinal disorders. The data leads us to believe that IMU-856 could clearly present a potential paradigm shift in how we treat gastrointestinal diseases. With dozens of endpoints investigated in this small exploratory trial, for which positive signals were detected across the board, IMU-856 demonstrated that it has a beneficial effect in treated celiac disease patients. We believe this data corroborates IMU-856 potential to regenerate the gut wall and restore a proper barrier function. As I noted earlier, we are now preparing for a clinical phase 2b testing of IMU-856 in ongoing active celiac disease patients. And just to reiterate, IMU-856 has the potential for broad development in other GI disorders too, where renewal of the gut wall is important, addressing multiple indications which are under evaluation. Now we made it through 45 slides, and we are now happy to have a Q&A session. Jessica, can you open the line?
Yeah, sure. Thank you very much both for walking us through the slides. We will now begin the question and answer session, which, just as a reminder, if you joined the webcast via the Zoom platform, there are two ways to submit your questions. You can either submit in writing via the Q&A tool of the Zoom portal, or if you would like to speak with us directly, please use the raise hand function of the Zoom portal to queue your question. Our first guest today is Yasmin Rahimi from Piper Sandler. Hey, Yasmin, please unmute yourself and go ahead.
Thank you, team, and really congrats to the outstanding data and also the really thoughtful preparation of all the data that you shared with us. I guess, team, the most imminent question for a lot of our investors are, given this outstanding data set, how soon, what are like broad strokes, design elements of a phase 2b? So, you know, what would a size of a phase 2b look like? What would the patient population be? Endpoints, any color that you could provide, and obviously that's not guidance, but just educate us about the opportunity in terms of next steps. And then also, what is the cost involved for running a phase 2b? And then the last aspect is there also interest at this junction to build indications beyond celiac disease, given the data that you shared, maybe a small open label study in Crohn's or UC? Would love to understand sort of the implication of these great results and the next steps and the timing and cost around it. And I'll jump back into the queue. And congrats again.
Hi, yes, this is Andreas. No, thank you for these very thoughtful questions and for the nice words. Maybe I start and then hand over to Daniel for the rest of the question. I can talk a little bit about phase 2b design. I think there's some precedent now because there are some drugs now in phase 2 development, but also we have the FDA guidance, which I think gives us some help in terms of where we should go with the further development of any drug candidate here in celiac disease. So I think we already pointed out that the patient population in a phase 2 trial would basically be an ongoing active celiac disease patients. These are patients that have a histological QMAR score of the stages M3, A, B, and C. They would also have to have some sort of signs or symptoms at baseline. So that's what the FDA requires. And I think we're a little bit more maybe flexible still on the endpoint end in the phase 2 study, but we often, and I think every pharmaceutical and biotech company does that, would like to test some of the phase 3 endpoints in a phase 2 setting as well. So the phase 3 endpoint that the FDA recommends for approval is basically a composite endpoint of improvement in histology and an improvement or no worsening in symptoms. So basically similar to other gastrointestinal diseases, this is the same division as, for example, you see in Crohn's, where you also have like these composite endpoints with an objective outcome and then a patient-reported outcome. This is the same for celiac disease, histology plus symptoms improvement. In a phase 2 trial, you probably want to have a more sensitive marker that allows you to get a more sensitive assessment of dose response. So I think this is we're still under discussion, but I think we had ongoing discussions with our medical advisors already over the last months in terms of how to design a phase 2 trial and what endpoints to take. But in general, that's the direction. In terms of size, I think it's usually you include like 3 active treatment arms and a placebo arm, and each of them are usually 60, 70 patients. So that's about the size that probably we'll do as well. But I think that's something that is not yet completely fixed. But I think we had the advantage of preparing for this day, and we know how to basically the design of a phase 2b trial should look like in terms of our next steps. But I think that's something maybe I hand over to Daniel in terms of other indications.
Yeah, what to do with it, I think, first of all, just to underline that it's a very clear way forward there, and very manageable amount of funding needed to do that. So this will not be a very expensive, huge trial. And I think we have a number of options to get there. And also, I think one point, maybe to your last question, it feels like we bought the entry ticket for the full GI space. And of course, that can have a couple of implications in looking on the industry, where the industry stands, what is currently there, how treatments look like, how would the future of treatments look like. Something like this could be an excellent maintenance treatment, could go beyond that. Maybe also thinking about combinations and so forth. So there's a lot you can think about, maybe more than we can talk about today in this call, but you feel our excitement about having such a tool now in hands.
Thank you so much for the commentary. And Andreas, just clarification, when you said 3 active arms versus placebo, 60 to 70 patients, is that per cohort or in total? I just wanted to clarify.
No. This is per cohort. Yes, sorry.
Okay,
this is the usual size.
Okay.
And by the way, I forgot to mention, I think very likely, and so in the phase 3 trial, the FDA would not like to see a gluten challenge. In the phase 2 trial, you may still want to do this, but I think you really, want to prepare for the phase 3 trial. So I think the phase 2 trial is something where you have no gluten exposure. You want to take these severe stages of disease, of celiac disease, and want to improve on it, similar to an IBD study, more or less, without gluten challenge. I forgot to mention that.
Yeah.
Got it. Thank you.
Thank you, Jas. The next one in the queue here is Andreas Argyrides from Wedbush. Andreas, please unmute yourself and go ahead.
Hey, good morning. Thanks for taking our question and congrats on the data here. Just 2 from us. Quickly, what do you consider a clinically meaningful impact on IL-2 following the gluten challenge? And then how do these data inform the selection of dose you're thinking about bringing forward? Thanks.
What do you consider? Sorry,
well, the IL-2.
Yeah, no, I got the first one. The second.
The dosing for
dosing.
Dosing. Okay. All right. Sorry. As always, I have trouble if I get 2 questions. Sorry. You already know this from previous webcasts. I'm trying to improve and it doesn't work. It's hard to say what clinically meaningful is in IL-2. And the reason is really that there is a huge variability in IL-2 for each of the trials that have been done. And so that there are, and it really depends on that these patients, or the immune stimulation on the first day of gluten challenge depends on what effect you get on IL-2, whether they had recent exposure to gluten, accidental exposure to gluten, which you can't avoid. Yeah, so and that's why you have this variability there. I do think that we have 2 test systems, and both test systems we have seen a very meaningful and what I would consider at least 30%, and even in one test much more of that, which is, I think, a very meaningful reduction. But there's no generally accepted level that you have to reach to basically be clinically meaningful, because IL-2 necessarily is a measure of immune stimulation in a gluten challenge study, but it correlates to symptoms, but there's no established clinically relevant level that you have to reach. And in terms of dosing in phase 2, I think, yeah, so this is still, of course, something that Daniel and I discussed it today, that is kind of more of an art than a science, to be quite honest, because both doses here in this trial were active. So this is good. This is good news. It seems like the 160 milligram dose is, in most endpoints, a little bit more active than 80. So you want to build your dose range for phase 2 around these doses, maybe going beyond in each direction a little bit. So that, I think, is my current thinking in terms of our current thinking in terms of how we would establish a dose response in a phase 2b trial.
Maybe I add something here, because Andreas, your question really, I think I know where it comes from. So on the biomarker side, when we designed this trial, we were putting every endpoint in to just record what do we see. And the big surprise here is that despite this short time frame we are covering, 4 weeks for treatment and only 2 weeks for the gluten challenge, we even have seen very strong effects here on the histology, and also, which is maybe, if you look on the later part of the presentation, the citrulline marker and the nutrient uptake, that is something we didn't even think you are able in this short time frame to really have these dramatic effects here. So all in all, I think the message of today, it goes beyond just the IL-2. It's really much more. We have these 4 dimensions which we cover in what we have seen on activity side here.
Great. Thanks again for taking our questions, and congrats on the data.
Thank you.
Thank you,
Thank you,
Andreas.
Andreas. Again, if you have a question, please use the raise hand function of the Zoom portal. And I actually received one message via the Q&A tool, which is from Tom Smith at SVB Securities. Thanks for taking the questions and for the comprehensive presentation. Can you comment on whether there was a dose response seen on the symptom improvement endpoints? And the second question, I think we just answered it. And how are you thinking about which doses to take forward into the phase 2b?
Yeah, I think the first question is, this is a relatively small trial, yes? And as you've seen, probably between 11 and 14 patients per treatment arm. And so patient-reported outcomes are inherently more subjective and more have more variability, interpatient variability. So I think I would really I would advise against looking at the symptoms data, or expecting from the symptoms data that you get with this number of patients a readout in dose response. You need more patients than that. And I think the more objectives markers like histology, citrulline, nutritional absorption really consistently show in most of them, I think, a very good and clear dose response. So in that respect, I think I would say that this really establishes a dose effector between these 2 doses, but 80 milligram definitely also has a good amount of efficacy already. It's probably not on the far lower end of effectiveness. So, and then in terms of dosing, I think for phase 2, I think I don't have anything more to say at this point.
We covered it, I think. Good. All right. We have one more in the queue. Raymond Wu from Ladenburg. Raymond, please unmute yourself and welcome.
Oh, hi, this is Raymond. Thanks for I'm in for Matt. Thanks for taking a question, and congrats on all the progress and results. Just one question, perhaps on the histology. I was wondering if you saw any difference in any of the patients showing improvement in villus heights while on treatment on 856. Were there more severe patients correlated with that change in height? Thanks.
So as you saw that in the waterfall plot, and thank you, Raymond, for the question. I think this is, of course, something that we want to evaluate further. But on the waterfall plot, and that's why we brought it up, the waterfall plot, you saw that it was, I think, like 5 or 6 patients. I think it was 6 patients in the active treatment arms that have an increase in villus height in this trial, despite the gluten challenge, which I personally think that's amazing, because you would expect a deterioration. But here the active treatment arms really showed this increase in villus height, not only for 1 or 2, but actually for, I think, 6 patients in all general. I hope I have the numbers right. And this is a mix of different stages of disease. So and it's probably not enough patients to really say that there's one or the other that is more prone towards improvement. But I think what's very encouraging is that the 2 improvements in the villus height to crypt death ratio that I showed you in the basically the QMAR scores, they are both the more advanced stages of the disease, which I think is good news for a phase 2b trial, that we were able with this mechanism of action to basically improve histology, even these severe stages of disease that are usually, at least from the literature, have been shown to really being very hard in terms of making any improvements on. And in that respect, I think this I think is a very valuable information for us that and for expectations and for planning of phase 2 study.
Oh, appreciate that detail. Yeah, thanks.
Thank you.
Great. Thank you, everybody, for the great questions. This concludes our question and answer session today. I would like to turn the webcast over back to Daniel for any closing remarks.
Yeah, thank you, Jessica. And at the end of this presentation, I would like to thank my colleagues at Immunic, in particular the 856 team, the patients which took part in this important clinical trial, our investigators in Australia and New Zealand for all their work and support. And finally, I want to thank you very much for listening and the good and open discussion we had. Thank you. Bye-bye.
Thank you very much for joining Immunic's webcast today. The call has now concluded. You may now disconnect.